Now we will move on to another important topic, attempted suicide and deliberate self-harm in Sri Lanka. Both terms, attempted suicide and deliberate self-harm, are used to indicate incidents where a person causes self-injury or ingests a substance intentionally. Main difference between the two terms is that in attempted suicide, there is a clear intent to die. In deliberate self-harm, suicidal intent is not clearly specified. Self-harm happens following an acute crisis amidst emotional distress. It is a cry for help. Motives are different from case to case. Person may have tried to release an emotion like shame, anger, or sadness. Some would be trying to communicate distress or escape distress. Some would have an intention to die. Please note that people rarely resort to self-harm to seek attention. All the patients presenting with self-harm should be screened for suicidal intent and undergo risk assessment for further self-harm. Some will have an underlying mental illness. When an older person presents with self-harm, it is more likely that he will be having higher suicidal intent and underlying mental illness. Now let us see how to do a suicidal risk assessment. If the person presents following a self-harm attempt, we should try to ascertain the suicidal intent of the act. Things that suggest high intent are prior planning of the attempt, trying to hide the act, not seeking help after the act, and resorting to lethal methods. Having mental illnesses like depression or alcohol use disorder will increase the suicidal risk. On mental state examination, having depressed mood or hopelessness will increase the risk. Also, we should clarify current suicidal intent, which may vary from no current intent, idea of better to be dead, having passive plans like if a bus was to run over me, having active plans, preparing and rehearsing the plans, and getting frequent ideas to die. Poor social support and ongoing social problems will also increase the risk. If you suspect that a person is having high suicidal risk, offer admission to a psychiatric unit and refer to specialist mental health team immediately for further assessment. If you think the risk is low, they can be managed in the community. Some of them may need further psychological support like counseling or social support. If you think the risk is moderate, assess each patient individually and decide the best course of action. If a person had more than one attempt, he should be referred to a mental health team. Now take some time and read these two case scenarios and think about management. In the first case scenario, it is clear that the further suicidal risk is high. The person is an elderly, has underlying alcohol dependency, has planned the act, tried to hide it, and has not sought help. Further, on examination, he is depressed and does not reveal his intent. He needs immediate assessment by a mental health specialist and admission to a psychiatry unit. In the second case scenario, the adolescent has taken the overdose following an acute crisis impulsively. At present, she is not depressed and has no further suicidal ideas. She can be managed in the community but needs counseling regarding coping in a crisis and regarding the relationship with her mother. Mother may also need support with regard to how to relate with a teenage daughter. Person with anxiety. Anxiety is also another mental illness with very high disease burden, which often goes undiagnosed at primary care. Anxiety is an emotion. Anxiety leads to adrenaline flow and sympathetic activation. This leads to psychological reactions of anxiety. Therefore, anxiety disorders can present with either psychological, physical, or behavioral presentations. Physical symptoms of anxiety disorder include symptoms like dizziness, sweating, difficulty in breathing, chest pain, palpitations, dry mouth, stomach problems, headache, or sleep problems. Panic attacks are due to sudden burst of anxiety leading to sudden, extensive physical symptoms which patients misinterpret as a cardiac event and is accompanied by intense fear. These often occur without warning and in sleep. Due to involvement of cardiovascular and respiratory symptoms, patients with anxiety symptoms often undergo unnecessary cardiac investigations. Persistent worries, feeling tense, irritability, phobias like social phobias and depression are some psychological symptoms in anxiety disorder. Depression and anxiety often present together. Substance use disorders and social withdrawal are some possible behavioral consequences of anxiety disorders. Differential diagnoses of anxiety disorder include depression, adjustment disorders, hypothyroidism, medications causing sympathetic overactivity, and substance use disorders like nicotine, alcohol, and cannabis abuse. Mild anxiety can be managed with relaxation, reassurance, pursuing hobbies, exercise, and improving life skills. Moderate to severe anxiety requires medications or therapy. First-line medications are SSRI like fluoxetine and sertraline. Therapy includes behavior therapy or cognitive behavior therapy. SSRI can increase anxiety initially, so you can prescribe small dose of benzodiazepines like alprazolam for first week of SSRI. Anxiety symptoms takes about 3 weeks of medications to wear off. Adjustment disorders are more mental health problems rather than illness. When our psychological reactions to changes in life become overwhelming, making adjustments difficult and affect our day to day functioning, we call them adjustment disorders. New situations could be loss events, role changes, and relationship problems. The ensuing emotions could be anger, depression, sadness, stress, and anxiety. Further, person can resort to maladaptive copings like substance abuse and self-harm. Adjustment disorder can be distinguished from normal adjustment by causing more distress and functional impairment. It is temporarily related to the event. Counseling is the primary technique in managing adjustment disorders. First, we should talk and listen to the client so that he can express his emotions out. Other coping methods like exercise, sports, religious activities, and art help the person to reduce emotions. Then one has to identify the actual problem without denial and avoidance. The real problem can be tackled with problem solving. Maladaptive copings have to be removed. Let's look into grief and bereavement. Grief is a normal psychological and behavioral response to any loss. Loss can be events like bereavement, partnership breakdown, exam loss, or loss of job. Bereavement is loss of a loved one due to death. What happens in grief is described in stages. Initially, person would go into shock and denial which can last few hours to a few days. Then person will start the grieving process. During this period, the person will feel various emotions like sadness, anger, frustration, loneliness, and even guilt. It is natural to cry and ruminate over the loss. It is also normal to hear the deceased person's voice or feel his presence. Gradually, grieving will reduce, leading to resolution and getting back to normal life. Whole process can take 6 to 12 months. If a client presents with normal grief, what we have to do is to educate them on normal grief and encourage them to grieve. They should use cultural and social grieving rituals. However, we should be aware of abnormal or pathological grief and refer them to specialized mental health teams. Pathological grief can be identified by various signs. One is that the person's grieving is intense, prolonged, or associated with maladaptive coping like substance abuse. Severe guilt and suicidal ideas are also a red flag. Some may be in prolonged denial. It is not uncommon that we encounter socially withdrawn persons. Socially withdrawn can be due to various reasons. One is that they may be suffering from severe social phobia, where people avoid social encounters due to fear of criticism. They may be avoiding social encounters due to depression. Negative symptoms and suspiciousness in schizophrenia, too, can lead patients to be withdrawn. Some may be just lacking social skills. Further, some may be having autistic spectrum disorders. Socially withdrawn persons should be assessed by mental health teams. Let's look into obsessive compulsive disorder, or OCD. The key symptoms of OCD include obsession, compulsion, and effects on normal function. Obsessions are intrusive cognitions that repeatedly come into mind. They are senseless, uncomfortable, unpleasant, are identified as his own cognitions, and are tried to be resisted. Failure to resist obsessions lead to anxiety. Obsessive cognitions can take the forms of thoughts like my hands are dirty, doubts like I did not switch off the electric iron, images of an unpleasant theme, ruminations of certain set of words, impulses like to stab a loved one, or certain rituals which need to be followed up meticulously. Obsessions may be clear or sometimes unclear. Obsessions lead to compulsions which reduce anxiety temporarily. Compulsions can be behaviors or cognitive forms which may be difficult to elicit. For example, a person who has obsessions of uncleanliness may have overt compulsions like washing hands excessively. Another person who experiences unpleasant obsessive impulses may recite prayers in mind as compulsions in order to overcome anxiety. Major step in managing a person with OCD is to educate the patient and family that the patient behaviors are due to an illness and can be treated. They need to understand the futility of rituals and reassurances. Please refer to the mental health team for specialized management. Treatment can be with antidepressant medications or psychotherapy or both. Mostly used medications are SSRIs like fluoxetine or tricyclic antidepressants like clomipramine. Therapy could be with CBT or behavior therapy. Exposure to obsessions, avoiding the compulsions, which is called exposure, and response prevention is a major technique in both techniques of therapies. There are some signs which suggest that the somatic symptoms may be due to a psychological problem. One such sign is the chronicity of the problem, leading to many consultations with various doctors and investigations. Another sign is that the symptoms are multiple and involve multiple systems, fluctuating among various systems. There may be temporal relationship with social problems. When we suspect that somatic symptoms may have an underlying psychiatric illness, we must first exclude depression and anxiety. As these two are fairly acute illnesses, we should include them in our differential diagnosis even at the first presentation, if somatic symptoms do not directly point to a physical pathology. Other two diagnoses we should consider are somatization disorder and hypochondriasis, especially if symptoms are chronic.